Thank you, Doctor. I request the next speaker, Dr. Shahnawaz B. Kaloo, to please come on stage to talk about cutting balloons and biodegradable stents.
I begin with thanking the organizers for the opportunity. I am Dr. Shahnawaz from X Hospital, New Delhi, and I will be talking about cutting balloons and biodegradable stents and their role in the benign biliary strictures. We all know that biliary strictures are broadly classified into benign and malignant strictures, and benign biliary strictures still represent a major challenge for the treatment, both for the patient as well as the physicians. The treatment duration is long, there are multiple admissions required, and multiple interventions are required, and even after that, their recurrence rates are still sizable. The treatment we are talking right now is the endoscopic treatment, like what we call ERCP. It is preferred because it is less invasive, and it can be done when there is no biliary dilatation, like in bile leaks. And PTBD, it is preferred in cases which have multiple anastomosis, the systems are separated, and cases where the ERCP fails, and the cases which have hepaticojejunostomy where the endoscopic approach is quite complex. The conventional tools in our armamentarium, both for the endoscopic and percutaneous route, are balloons, plastic stents, self-expanding metallic stents covered, and percutaneous catheters. And the treatment's principle remains the same for the endoscopic as well as for the percutaneous route. The principle is sustained dilatation of the stricture, which continues for many weeks to months. This can be achieved by percutaneous catheters, or multiple plastic stents, or by placement of covered stents. And this principle has shown efficacy, a success rate of more than 80% in the literature. But there are multiple challenges which remain. The first challenge I am discussing here is resistant strictures, or those strictures which are not yielding to the conventional balloon dilatation and catheter placements. For these strictures, cutting balloon is an excellent choice. This is a picture of a cutting balloon in its inflated state. We can see that there are longitudinal atherotomes, these are called as, basically these are microsurgical blades placed on its surface. With these atherotomes, when the balloon is inflated, it creates a small nick or a micro incision on the wall of the duct, and this helps in dilating it even at very low pressures. Subsequent to the dilatation by a cutting balloon, a conventional balloon can be used to make the diameter of an adequate size. This method has allowed us for the dilatation of the strictures more easily to a larger diameter that can be achieved with the conventional balloons. And there are multiple studies to support this. This study, one of the earliest, shows that the success rate with cutting balloons is more than 90% in patients who had liver transplant recipients. Another study, this is from ILBS, and they showed that cutting balloons are successful in almost all cases without any major complication, and the patient population was those who had edge strictures. So the advantage with cutting balloon is that it can be used for refractory benign biliary strictures where the fibrotic burden is huge, and it doesn't have any major complication. There are no reported cases of biliary ruptures or major hemophilia. However, there are limitations, like there can be minor hemophilia which may need catheter external drainage for a few days, and it is only suitable for percutaneous route. There are no endoscopic balloons available. Next, we come to the biodegradable stents, which are a newer thing and probably a little more exciting. We just talked about the challenges in the benign biliary strictures, and specifically if we talk about the percutaneous route, the challenges are manifold. The catheter is dangling from the body of the patient, which causes discomfort, pain, and patients who are traveling, it might hamper their security check-ins and other things. Patients need repeating dressings, and if these catheters, there is pericatheter leak, this is quite bothersome. This bothers the patients most, and sometimes it even causes skin induration and cellulites, and there is no way to go except to remove the catheter. But all these challenges can probably be addressed with the covered stents. But then there is another challenge. Most of the biliary strictures we are seeing in our practice are post-transplant strictures. And these are the high biliary strictures or hilar biliary strictures. And covered stents are not suitable for hilar biliary strictures because they can cause obstruction or jailing of the side branches like this, and which leads to the cholangitis. And we go back to the plastic stents, but we know they are small diameter, need frequent changing. Here comes the idea of the biodegradable stent. The idea basically is that a stent, once it completes its mission, should disappear in the body, and there should be no need to remove it. This will help us in many ways. There will be less number of hospital admissions, less number of interventions required, and there will be no external catheter dangling from the body of the patient. This might also be suitable for the hilar strictures because these stents are made of mesh and does not jail the side branches. So the indications which are still evolving and expanding are resistant and recurrent biliary strictures, for which there are multiple studies available. In our practice, we have also used these stents for patients who showed poor tolerance to the percutaneous catheters or who didn't want to have a repeat procedure. This is our protocol we follow in our hospital. So, is there a pointer? So in our practice, if we come across a biliary stricture, if it is hepaticojejunostomy stricture, we usually go for PTBD. Very uncommonly, we may go for a redo HJ. After PTBD is done, we go for serial upsizing, and mostly it does the job. But many a times, the patient may not tolerate once the catheter sizes increases, especially after 14 French. Or there may be a residual stricture even after we achieve the highest size of the catheter. In these two categories of the patients, we are offering biodegradable stents. These patients who have duct-to-duct anastomosis with ductal strictures, these many a times go for ERCP and some go to PTBD as case-to-case basis. After PTBD is done, we go for a serial upsizing of the catheters, and most of the patients tolerate it well and the treatment is completed. But there can be patients who do not tolerate it, or there are residual strictures even after the highest size of catheter is utilized. For patients not tolerating it, we are currently offering them the plastic stents, which are placed percutaneously and planned to be removed or exchanged after 3 months endoscopically. But these patients can also be offered biodegradable stents. The only challenge in our practice is the cost. But those patients who have residual stricture, even after using the largest bore catheter, we are offering them biodegradable stents. These are. So, there are 2 biodegradable stents we have used which are currently available. Though there are more upcoming stents, but in our practice we have used these 2. One is DV stent by Ella. This is the stent. And the other is the Archimedes developed by the Q3 Medical. DV Ella is a self-expanding stent. It is made of polydioxanone, which is basically the same material which is used for manufacturing the surgical sutures. And the stent integrity and its force is maintained for 6 to 8 weeks, and the degradation is complete by 3 to 6 months. One thing to note here is that this stent is not visible under X-ray, under fluoroscopy. So there are two gold markers at each end of the stent like this, which help us localizing the stent. Once I will show you the images, so it will become more clear. Additionally, this stent comes separately packed, not in the delivery system, so you have to load it manually on the delivery system and deploy it. The largest diameter is 8 and 10 mm available, and lengths are available up to 8 centimeter. The delivery system is bulky. It is more than 11 French. This makes it non-compatible to the endoscopy. There is another stent. This is Archimedes stent. This is make a polymer called as polylactic acid. It is a helically shaped stent, and the bile flow is in the crevices between the ridges. It is compatible with the endoscope, and it has better fluoroscopic visibility. And it comes in 3 strengths which last from 12 days to 11 weeks, depending upon their strength. I present briefly our experience. We have done 5 patients with bioabsorbable stents, and we placed 6 stents in them. In 3 patients, we placed DVLR stent. In 2 patients, we placed Archimedes. All these patients were post-transplant strictures. 3 patients had edge strictures, and 2 patients had duct anastomotic stricture. Mean follow-up was 15 months. We didn't encounter any case of recurrence till now. We didn't see any major complication or any major episode of cholangitis. This is one case. This gentleman had undergone PTBD, which had been there serially upsized and was kept for 9 months. Still the stricture was there. Then we placed this stent, and he is doing fine. Another gentleman with a left lobe graft. This is a post-transplant where we did this DVLR stent. This gentleman has duct-to-duct anastomotic site stenosis, and there were 2 anastomoses. So we had to place 2 stents. The stent itself cannot be seen, but the contrast in the lumen of the stent can be seen. And yes, these stents, because they are made of mesh, so we expect them that they will be helpful even if the side branches are jailed. There are multiple studies to prove their efficacy. This study has 18 patients post-liver transplant. They showed a complete resolution rate of strictures in 72% patients. Another study with edge strictures showed complete resolution in 84%, more than 84% cases. Another study which had pediatric as well as the adult liver transplant recipients, they showed an anastomotic stricture group had 81% of efficacy, and non-anastomotic strictures around 50%, which is decent. And there are smaller case reports and studies which are again show their efficacy. There have been a minor concern of cholangitis, because once these stents break, they do not dissolve in the body actually. They break and fragment, and they can cause clumping and occasional episode of cholangitis. That is the only concern. So I summarize that biodegradable stents can provide at least the same results with our standard treatment, but with a lesser number of hospital admissions, lesser annoyance to the patient, and much better patient tolerance. There are still limitations with episodes of acute cholangitis, and cost is a major concern. These stents cost almost 5 times the cost of a routine stent. In future, we may see drug-eluting biodegradable biliary stents, and paclitaxel is being studied in this role. I thank you all